The following podcast is part of a certified educational activity titled The Road Ahead for Enhanced Sequential Care in CLL, Updates with Targeted Therapy. Access the entire activity and complete the post-test at peerview.com/UMD860. Downloadable slides are also available.
Hello, and welcome to The Road Ahead for Enhanced Sequential Care in CLL. I'm Dr. Jennifer Wyack from The Ohio State University, and I'm pleased to be joined today by my colleague, Dr. Toby Eyre from Oxford University Hospital's NHS Trust. Today, we're going to discuss how real-world data, patient views and preferences, and practice-changing clinical evidence are shaping sequential treatment choices in relapsed and refractory CLL. At the close of this program, Toby and I will discuss a modern sequential treatment algorithm and provide some guidance on how we can make informed treatment decisions for patients progressing on initial therapy. We're providing a downloadable version of this algorithm as a practice aid, so you may want to access this resource now. Let's begin. So during this presentation, we're going to discuss some of the current guidelines for sequential treatment in CLL. We'll discuss clinical evidence, which supports the use of time-limited therapy with BTK inhibitor components, as well as the use of non-covalent BTK inhibitors after prior covalent BTK inhibitors. We'll talk about how we might choose sequential therapy in CLL. And then finally, we'll talk about the importance of a multidisciplinary team and working closely using patient-centered care as well to help address safety, dosing, and therapy considerations when managing relapsed refractory disease. Here's some real-world data to show how practice patterns have shifted with the introduction of targeted agents in CLL. So this is looking at cohorts of patients treated in 2014 compared to 2021. And as you can see, chemoimmunotherapy usage has dropped really dramatically as novel agents have been more and more utilized. However, there still are a substantial number of patients who are receiving chemoimmunotherapy in the frontline setting, suggesting that still we need more data and more education regarding the use of novel therapies in frontline CLL. You can see in parallel with the decrease of chemoimmunotherapy, more and more patients being treated with BTK inhibitors and BCL2 inhibitor venetoclax coming into the market and into popularity as well. I think if we looked up to 2025, we would probably see even more decrease in chemoimmunotherapy usage, as well as more patients treated with fixed duration regimens, including venetoclax. There's some interesting data presented at the 2025 EHA meeting looking at real-world data from Canada, where they took a cohort of patients who discontinued a covalent BTK inhibitor and from their next treatment looked at the time to next treatment or death. And you can see that that time to next treatment or death was actually very short, only 12 months. And this were some patients who progressed while taking that covalent BTK inhibitor, some who had likely discontinued for other reasons, but showing us that we really still need to both do work to increase the options available for relapsed refractory CLL, but also do more work in education to make sure that people have plans for how they're going to sequentially treat patients in their practice. I'd like to take a moment to mention the CLL Society, who is our partner in this program. I'm going to show you some data in a minute on a survey study that was undertaken with PeerView and the CLL Society. This organization has a lot of knowledge and support materials for patients. You can see a couple QR codes to look at needs of immunocompromised patients, as well as a guide for taking care of patients who are immunocompromised with blood cancers. And I encourage you to look at these resources. So getting to the data from the survey, so this is a survey looking at 219 patients. It was conducted in March to May of 2025, and patients were asked to answer a variety of questions regarding their opinions on their CLL journey. Good news is that about 2/3 of patients reported that their healthcare team provided consistent guidance, so education and encouragement as patients were undergoing therapy and even in the time prior to treatment. Interestingly, though, a little over a quarter of patients noted that after frontline therapy, their guidance and their encouragement decreased. And probably a lot of this is due to either lack of data or lack of familiarity with what we're going to do with patients as they're treated in the second line and beyond. A very small minority of patients said they didn't receive any meaningful encouragement in their CLL. So, when looking at people who were currently in remission, when asked for their concern that was kind of their biggest concern in clinical practice now, most of the patients said that it was worries over treatment options after relapse. So they didn't know what they were going to get as their next treatment. As well, there is a lot of anxiety about potential treatment related toxicity, fear of relapse, for those on continuous treatment, stress over adherence. And then for a few people who are undergoing fixed duration therapy, concerned that maybe their fixed duration therapy wasn't going to be sufficient. As well, they asked patients what they wanted their healthcare providers to prioritize when discussing their relapsed refractory CLL therapy. And you can see here there was a variety of responses. Some of the ones that were most commonly noted were discussing side effects and tolerability, discussing long-term effectiveness, quality of life, long-term harmful effects, and where their treatment was going to happen, whether it was something that they were just going to take at home versus something they had to come into the clinic for. So now I'd like to turn it over to Toby to talk a little bit about the treatment algorithms that we're currently using in the United States and in Europe.
Thanks very much, Jen. That's an excellent introduction. So obviously we've got a range of treatments that have been in development over recent years, and we're going to discuss some of the data supporting these options later in the video. As you can see here, this is the European Society of Medical Oncology, or the ESMO clinical guidelines published last year. And I think the first point here really is that you can see increasingly we're dividing therapeutic options according to genetic status. It was historically the case that we would divide by people's age and fitness, but you can see here division according to risk, I think, is increasingly important, with patients who have low risk disease, i.e. IGVH mutated, TP53 intact disease. Generally, the favored approach for both older and younger patients is fixed duration therapy. In patients with a TP53 mutation or deletion, generally the favored approach is a continuous covalent BTK inhibitor in the first line. And I think it's fair to say in that intermediate group where patients have IGVH unmutated disease and TP53 intact disease, all options I think are valid, and there's clearly a lot of discussion to have with patients over their preferences and to ensure you're individualizing therapy according to comorbidities and patient wishes. The ESMO guidelines in the relapsed refractory setting make note of the possibility of venetoclax-based retreatment. Now, the thresholds here are somewhat arbitrary in terms of recommendation, but broadly speaking, venetoclax-based retreatment seems to be a viable option in patients who relapse greater than or equal to 3 years after initial or previous venetoclax-based treatment. Those who relapse earlier than that could be treated with venetoclax therapy, but there's really a relative paucity of data, as we'll discuss later, regarding venetoclax-based retreatment. In patients with TP53 mutation or deletion, one should be considering covalent BTK inhibitors, venetoclax-based therapy, and potentially allogeneic stem cell transplant at an appropriate time point, depending on the patient's age and fitness. And in those patients who progress on a covalent BTK inhibitor, non-covalent BTK inhibitors are a possibility now, and pirtobrutinib has received European approval in recent times, and patients who progress on a covalent BTK inhibitor, this is an option. The NCCN guidelines have broadly a similar approach. In the first line treatment setting, venetoclax-based therapies in combination with CD20 antibody, or BTK inhibitor with or without a CD20 antibody are both category 1 designated therapies. And then covalent BTK inhibitors, acalabrutinib plus or minus obinutuzumab, and zanubrutinib are both recommended options. In those patients who have a TP53 mutation or deletion, all of these considerations are options again. But I think it is recognized that continuous covalent BTK inhibitors deliver the most durable disease control in the first line setting in this situation. As you can see, ibrutinib monotherapy it remains an option, although I think is used less and less as a monotherapy. And ibrutinib venetoclax used in Europe and licensed and approved in Europe, but not so in the US, and so that's got a category 2A designation. In the relapsed refractory setting, again, the sequencing of therapy describes a number of options, as we'll talk about later, with pirtobrutinib there in patients who are resistant or intolerant to prior covalent BTK inhibitors, both in those who do or don't have a TP53 deletion or mutation. Now, there is a relatively new category of therapeutic options for patients who are considered refractory or have relapsed after a prior covalent BTK inhibitor and prior venetoclax-based therapy. This is a challenging group of patients that we are starting to see more in our clinical practice. In the US, liso-cel, so the anti-CD19 CAR T-cell therapy, is approved, as is pirtobrutinib in this setting if previously non-covalent naive. And then there are a range of, I think it would be fair to say, historical therapies that may have value on occasions. Agents such as the anti-CD52 targeting antibody alemtuzumab, and also agents such as lenalidomide and PI3 kinase inhibitors. So here's a summary, really, of the regulatory status of BTK inhibitors and BCL2 inhibitors in CLL. As you can see here, the covalent BTK inhibitors are really approved in the US and in Europe. In Europe, ibrutinib is, as mentioned, approved in combination with venetoclax. Acalabrutinib also as time-limited therapy with venetoclax with or without obinutuzumab, and zanubrutinib as monotherapy. Pirtobrutinib is approved in the US in relapsed refractory disease and also in Europe following a covalent BTK inhibitor. And nemtabrutinib remains in phase 3 studies with venetoclax-based therapy approved in multiple settings with or without CD20 antibody. So with that summary, you'll see that there's a lot going on in the CLL field, and I'm going to hand over to Jen to talk through the next steps of time-limited therapy with BTK and BCL2 regimes in CLL.
Thanks, Toby. The time-limited BTK inhibitor, BCL2 inhibitor regimens have really exploded over the last few years. The first regimen that has been studied was the first-generation BTK inhibitor ibrutinib with venetoclax, and this was tested in a variety of different settings. Here's some data recently presented on the Captivate study. This is the fixed-duration cohort where everybody received 12 cycles of the combination. These data go out to 5.5 years now, with a 5.5-year progression-free survival of 60% for all patients. And you can see that this is a little bit lower for patients who have an alteration in TP53, and slightly lower for those with IgHV unmutated disease, as we've seen with most fixed-duration regimens. Importantly, though, the overall survival at this time in this fixed duration cohort is 96%, suggesting that there are going to be a lot of successful ways to treat patients after this type of regimen. Captivate did look at the potential of BTK inhibitor retreatment, either with ibrutinib alone or ibrutinib plus venetoclax. You can see some of these data here. In both of these cohorts, the overall response rate was about 80%. For those people who received another year of ibrutinib plus venetoclax, the 1-year PFS and overall survival is 100%. That's really to be expected. Those patients are still on treatment at that time with the doublet. And for those patients who went on to get ibrutinib ibrutinib as a single agent given continuously, the 2-year PFS and overall survival was 91% for progression-free survival and 96% for overall survival. So very encouraging results there. The FLAIR study is a more recent trial, and this is also studying ibrutinib plus venetoclax in the frontline setting. But here, this is an MRD guided approach where each patient was treated for a different period of time, depending on how long it took them to get to undetectable MRD. That time was then doubled. So patients were treated for a minimum of 2 years and could be treated for, I think, up to 6 years on this study. The progression-free survival is really excellent and much better for ibrutinib plus venetoclax versus FCR. And so this is the first trial that is looking at has looked at ibrutinib plus venetoclax in an MRD guided fashion compared to ibrutinib alone. And at EHA this year, we saw the first data showing actually a survival advantage to ibrutinib plus venetoclax over ibrutinib given as a single agent. So that's very exciting. Another combination that has been really well studied and is now been studied in the phase 3 trial setting are acalabrutinib combinations. This is the AMPLIFY trial, which compared chemoimmunotherapy to either acalabrutinib plus venetoclax or acalabrutinib plus venetoclax plus obinutuzumab. We saw these data at ASH in 2024, where both of the acalabrutinib combinations were superior to chemoimmunotherapy. Both of the combinations were given for 1 year. One thing that was quite different in terms of the two combination acalabrutinib regimens was minimal residual disease at the end of therapy, where for patients treated with the triplet, acalabrutinib, venetoclax, obinutuzumab, 65% achieved undetectable minimal residual disease, whereas for acalabrutinib plus venetoclax itself, only 30% of people achieved undetectable MRD. In the short time frame that we followed people for progression-free survival, there's not too much of a difference, especially for those patients with mutated IGHV, although the curves have even started to separate in the initial presentation for those with unmutated IGHV, where they appear to do a little bit better at this time period, although not directly comparable with the triplet compared to the doublet. Here we're looking at MRD kinetics, and we can see that for the majority of patients who achieved undetectable MRD, this is persisting over time. We see this, that the stability of undetectable MRD is higher, so more stable in those patients with mutated IGHV compared with those who have unmutated IGHV. Importantly, though, some of the efficacy benefits of ABO are outweighed for some patients by toxicity, where toxicity, especially infectious toxicity, and specifically in this trial, COVID, were much higher for patients treated with the triplet regimen versus the doublet. And then actually the chemoimmunotherapy was fairly similar to the doublet regimen. So overall, some very exciting data with these BTK, BCL2 inhibitor combinations. So then thinking a little to the future, so what's next with these time-limited targeted regimens? A couple of studies that are in progress that have completed enrollment, but we haven't seen results yet. The first is the MAGIC study. So this is a really exciting trial, which is comparing acalabrutinib plus venetoclax to venetoclax obinutuzumab, where these fixed duration combinations are given in an MRD guided manner. So those patients who don't have undetectable MRD after the first year of treatment can go on to receive an additional 12 months of treatment. So these are some data that will be excited to see in the future. Another trial that has completed enrollment but yet to read out is the Celestial TN study. And so this is looking at a newer combination, zanubrutinib plus sonrotoclax versus venetoclax plus obinutuzumab. This study is a 1-year treatment duration for both of the two arms. So this is a fixed duration. It does not have an MRD guided approach to it. And then another exciting new combination that has been studied in a single center trial is pirtobrutinib, venetoclax, obinutuzumab in frontline CLL. Here you can see data looking at the minimal residual disease status at cycle 7 and cycle 13 in both the blood and the bone marrow. And you can see extremely high rates of undetectable MRD in patients treated with PBO at these time periods. This study is very early, so with a median follow-up of 11.9 months. So again, people are generally still on treatment. No patient has progressed or died. And I'll turn it back over to Toby. Can you tell to us a little bit about some of the newer BTK inhibitor-based strategies?
Thanks very much, Jen. Great overview of what's happening in the first line treatment setting. So moving to the relapse refractory setting, we've seen the first randomized trial actually presented and published in patients who've had a prior, exclusively had a prior targeted inhibitor. So this is the Bruin CLL 321 trial, where all patients were enrolled and had a prior covalent BTK inhibitor, and approximately half had prior venetoclax-based treatment. And pirtobrutinib was tested against the investigator control arm of idelalisib or bendamustine rituximab. It was a modest phase clinical trial, but pirtobrutinib demonstrated an improvement in progression-free survival compared to the investigator control arm, with a reduction in risk of death or progression of 46%, with a median progression-free survival of 14 months in the pirtobrutinib arm and 8.7 months in the control arm, bearing in mind this was an extremely heavily pretreated and high genetic risk patient population. The clinical trial demonstrated a consistent benefit with pirtobrutinib across a range of relevant subgroups. Now, of course, this trial is relatively small, and so the confidence intervals are quite wide. But as you can see there, the direction on the forest plot demonstrates benefit for pirtobrutinib across all subgroups where there is a reasonable number of patients, including those with a p53 deletion or mutation. I think one of the really important things about pirtobrutinib and about BTK inhibitors in general is actually you can gain clinical benefit by treating patients beyond, for example, radiological or early clinical progression. And this is demonstrated very nicely here in the time to next treatment Kaplan-Meier curve from this clinical trial, where actually there was an extension of benefit to pirtobrutinib here with a median time to next treatment of 24 months compared to just under 11 months in the control arm. So it's quite a substantial gain in terms of clinical benefit beyond simply the progression-free survival. And this is a clinically relevant outcome in the context of the patient group being studied here, who've had a median of 3 prior lines of therapy. Now, alongside this, when disease control is better and you have a well-tolerated agent, quality of life also generally improves. And here are a summary of the patient-reported outcomes, suggesting a clinically relevant improvement in CLL-related symptoms, physical function, and fatigue with pirtobrutinib compared with the control arm across the first 6 months of therapy. From an adverse event profile as well, the results favored pirtobrutinib. Broadly speaking, there was an improvement in overall adverse events, and also stopping for discontinuation was less common in the stopping for toxicity was also less common in the pirtobrutinib arm. You can see here a list of adverse events of particular interest that we often look out for with BTK inhibitors, and you can see really the risk of grade 3-4 bruising and bleeding, the risk of hypertension, atrial fibrillation, broadly speaking, are very low. Now, there were some infectious complications in this study, but of course, one must consider the context of the trial in heavily pretreated, high-risk patients. Now, there are a number of other studies of pirtobrutinib from the initial phase 1/2 clinical trial, which is a very large phase 1/2 study of approximately 800 patients, Within that, there was a useful subgroup of 127 patients who previously received a covalent BTK inhibitor, but were intolerant of this, but hadn't had progression on the covalent BTK inhibitor. So the aim of this sub-study was really to investigate whether those same adverse events recurred on pirtobrutinib and whether it could be well tolerated or not in that particular setting. And as you can see, the discontinuation rate of pirtobrutinib due to a treatment-related adverse event in this context was only 5.5%, so only 7 patients out of the 127 enrolled. And actually, if you look at response rates in these patients, they were excellent and consistent with the overall population in the Bruin study. And you can see here listed the overall response rate of just under 77% in the 78 CLL patients. So this certainly supports the use of pirtobrutinib in covalent BTK intolerant patients. Of course, what it doesn't answer is whether you should use a separate covalent BTK inhibitor or indeed a non-covalent BTK inhibitor in patients who are intolerant, say, to a first-generation covalent BTK inhibitor. And that's very much up for debate. But this is a very robust data set, certainly supporting pirtobrutinib's use here. Now, of course, the more options we have, the more complex things get in the relapsed refractory setting. And of course, we'll in the future have, and now, of course, have the option of BCL2 inhibitors, non-covalent BTK inhibitors, and covalent BTK inhibitors are 3 core modalities of choice. Most of the clinical studies of non-covalent BTK inhibitors have had treated patients with prior venetoclax-based therapy, but certainly by no means all. And so the question also arises is how do patients who are venetoclax naive do after they progress through a covalent and non-covalent BTK inhibitor and then receive venetoclax-based therapy following this? Fortunately, there's some very useful data from ASH last year, nearly 50 patients who've been studied here, and you can see patients respond and they gain clinical benefit from venetoclax-based therapy with a median progression-free survival of just under 2 years. And so this certainly this field is evolving, and understanding sequencing in this space, I think, is relatively limited by the real-world data that we have at present, but I'm sure this will evolve over time. Another way to target BTK is by degrading the BTK protein. This works through a target binder which latches onto the E3 ligase binder and then brings BTK in contact with E3 ligase, and that leads to ubiquitination and then proteasome degradation. So you can target a specific protein within a cell by developing a specific degrader to that protein. So very exciting concept. And BTK is a natural initial target in lymphoid disease, and you can see there are different agents in development. Now, we've seen relatively small data sets over the last year or so looking at both BGB-16673 and the Nurex compound, which now has a name, which is bexobrutideg. And nearly 50 patients studied with that agent with overall response rates of 80%, and the BGB-16673 also similar response rate in a broadly similar patient group. So both of these agents looking highly efficacious and also, generally speaking, at the moment, well tolerated, although, of course, a relatively small sample size with relatively short follow-up. There's activity with these degraders in patients who've had a prior covalent and non-covalent BTK inhibitor. So lots happening in CLL. I will now hand over to Jen for a discussion about the present and future care in CLL, and we'll talk about how the landscape is evolving.
That's great, Toby. Thank you. So now we'd like to talk through some different scenarios for how we choose the best sequential therapy for patients. First, we wanted to just bring up some of the factors that inform the therapeutic decisions in regards to sequencing. So there's a number of things that we can take into account and we should be taking into account when thinking about what's going to be the next therapy for our patients. In some cases, it's going to be access to therapy, either because of financial limitations or just access in a particular area. Another consideration is going to be availability of clinical trials. So, are there potentially new agents, new approaches that can be available for a specific patient? And in those cases, those often should be prioritized over some of these standard of care approaches. But when thinking about the standard of care approaches, we want to be thinking about what is the treatment history. And that's probably the number one consideration because, of course, the treatment that a patient received before and their response to that therapy is going to help us choose our next treatment. And then, in addition to that, patient goals and priorities. So, do they really want a treatment free interval if possible? Do they prefer something that would be a continuous therapy and is easy to take? And then, really, what are the goals of therapy and the treatment destination? Is somebody interested in doing CAR T cells? Are they, even potentially interested in an allogeneic stem cell transplant if they're young and have very high risk disease? And when thinking about long-term goals, that helps us shape our short-term goals for the next treatment as well. And then, of course, for individual patients, what is going to be the expected safety and tolerability? Do we have to think about comorbidities? Do we have to think about concomitant medications and things like that? So let's think about some different scenarios. So what happens when we start with a covalent BTK inhibitor, either given alone or with the CD20 monoclonal antibody? I'll preface this to say that because we have all these agents, when we're discussing frontline therapy with patients, it's important to emphasize to them that there are many options even beyond the frontline therapy. There's a lot of different ways we can sequence things, and that the treatment decisions will change some of the decisions later on, but don't necessarily eliminate a lot of options in the future. So people who have received a covalent BTK inhibitor at the time of relapse, presuming that they had progression while taking the covalent BTK inhibitor, our options would be either a time-limited BCL2 inhibitor-based combination. Here, we're primarily looking with a CD20 monoclonal antibody, or a non-covalent BTK inhibitor. Here, when I'm thinking about this with our patients, when I'm talking with patients, a lot of this comes down to logistics. Do they want to have a treatment-free interval since they haven't had one before? Do they want something that's going to be just as well tolerated as what they took before, potentially even better tolerated in the case of pirtobrutinib? And that is a lot of the discussion, which kind of mirrors the discussion that we had in the frontline setting. Toby, when you're making that initial decision, what kind of things are you discussing with patients, or what do they tend to see as the most important?
That's a great question. I mean, I think just looking at this initial algorithm, Jen, I'd also just comment on the fact that we are effectively extrapolating data that has been generated in really slightly different settings to this. And it's natural that this is now what we face. But if you think about, for example, the Murano study, BTK inhibitor, effectively naive population, the Bruin 321 study, heavily pretreated patients, high-risk disease. And yet here we are, we're talking about potentially second-line patients where both of those therapies are sort of potential options. I think you summarized it really well. I think ultimately we know non-covalent BTK inhibitors and BCL2 based therapy are the most active therapies here. I think I would present both options much in the way as I would in the first line setting, and patient preference, logistics, and just the sort of sequencing pathway and how a patient might want to play that, I think are really key determining factors. Maybe the delivery center people are in potentially the experience of the physician. I think those do influence decisions as well. So there's a whole range of factors that influence therapeutic choices here, whether a patient likes the idea of stopping therapy. Now, I think in this particular setting, of course, all of these patients have sort of probably chosen continuous therapy previously. And so certainly the concept and the idea of that continuing, I don't think is probably going to be a major issue for a lot of people. But it's very individualized, I have to say.
Yeah, great. I think that's a great point, too, that a lot of what we talk about in terms of the sequencing is extrapolated from both retrospective studies that actually look at these particular sequences, but all the prospective studies, as you mentioned, are really not in this same scenario. And yeah, I think you're absolutely correct. So this is a population that has been treated for many years with a covalent BTK inhibitor. Many of the ones who tolerate it well like the idea of just continuing on this pathway where they get a different BTK inhibitor that's also going to be given in a continuous manner. I like to make sure we point out to patients, though, that if a time limit or time off treatment is important to them, outside of CAR T cells or maybe transplant or things like that, they probably need to choose the BCL2 based regimen right now, because the more lines of therapy you get, the less likely it is that they're going to have a very meaningful time off treatment when they get to that venetoclax based therapy. Also, probably important to note, like in the United States, a lot of times we extrapolate the CLL13 data and give obinutuzumab in the second line setting, whereas that's not an available option everywhere.
Yeah, so we don't have the approval of that. I absolutely take your point that if you have a patient who really time limited therapy and time off therapy is a really key driver for decision making, then really you're talking about the first line setting and maybe this setting as a stretch, because and beyond that, as you say, highly unlikely to get much durable time off therapy in most patients. And actually, we don't have good prospective data to know, for example, how long 2 years of BCL2 CD20 antibody even works for in this setting. We might have some in future clinical trials, but at the moment, we can't tell a patient with great confidence in this space whether they'll get 2, 3, 4 years off therapy or whether it'll be a few months. So certainly something that I think we need to learn more about.
Yeah, absolutely. And then, of course, based upon that decision in the second line setting opens up different options in the third line setting. So people who went on to a non-covalent BTK inhibitor, really after that, it's a venetoclax or BCL2 inhibitor based regimen. Those that did a fixed duration, there's a potential for retreatment. Again, not knowing how long that remission is going to last in the second line setting, it's hard to know how likely it is to get that retreatment option. They can, of course, then go to a non-covalent BTK inhibitor, and in the US, can go to CAR T cells at that time as well. Toby, any other comments you want to make on this algorithm?
No, I think, well, just that it's getting increasingly complicated, but that we have the blessing of all these very active therapies, that if you have somebody who progresses through a covalent BTK inhibitor first line, particularly if they have high risk genetics or they're young, then they will likely sequence through a number of these therapies. And of course, we don't have high level evidence for knowing which direction to take. We don't have CAR T cell therapy at the moment in the UK and in mainland Europe. And I think it's fair to say we await development plans for that at present. So yes, I don't think that's going to be available anywhere in the near future. But of course, we know CAR T is an active modality, and certainly I'd be looking to clinical trials and so forth for patients who may need that therapeutic approach sort of in the relapse refractory setting.
Yeah, absolutely. So Toby, I'll turn it over to you to take us through our next algorithm.
Thanks, Jen. So we were obviously talking about covalent BTK inhibitors first line. Of course, one of the main other therapeutic options first line in treatment naive patients is to use CD20 BCL2 based therapy. So CLL13, CLL14 have demonstrated the activity of venetoclax plus obinutuzumab in untreated patients, both older with comorbidities and younger. And those studies have been very valuable at giving us a real feel for how well those patients really fare in the first line setting. But I think where evidence really is limited at the moment is what treatment options, what approaches should be used in patients who relapse after that therapy. We do have data to suggest that actually BCL2 based mutations are quite uncommon after fixed duration therapy, both from the German CLL study group, but also from the Morano study in relapsed disease. So sort of conceptually, at least, retreatment with BCL2 inhibitor-based therapy is a very reasonable approach. And there's data that's been generated from the relapsed refractory setting, and both real-world data and also from the Morano studies certainly suggest that conceptually it's a very reasonable thing to do. But actually, we have very limited data in this particular space, i.e. first line to second line, to really sort of firm down how patients will do with BCL2-based retreatment with fixed duration. But I think it's a viable treatment option, and a study called the REVENG study is really looking at this in detail. Similarly, we don't actually have any prospective clinical trials, as far as I'm aware, of covalent BTK inhibitors after BCL2-based therapy. But naturally and understandably, given the mechanism of action being very distinct from BCL2-based therapy, certainly a viable therapeutic option. And some might argue that if patients relapse early, particularly potentially those who have unmutated disease or P53 deleted disease, covalent BTK inhibitors subsequently may be very reasonable. And there is a couple of data sets that are in the literature, again, generally sort of pooled real world data sets from international groups looking at covalent BTK inhibitors after BCL2 inhibitors, and certainly that there's proof of principle that they are very active there. So that's the main treatment, I suppose, options in this setting. And then beyond that point, really, again, it's a case, I think, of what have patients been exposed to, what have they tolerated well, and what are they resistant to? And so if you look along the top algorithm, of course, patients are covalent BTK naive, and so a covalent BTK inhibitor is the next natural thing given to progression or toxicity. And then beyond that point, these patients are probably double refractory, and so non-covalent BTK inhibitors and CAR T-cell therapy are probably reasonable. If you give fixed duration BCL2-based therapy and then a covalent BTK inhibitor, I think options are even broader because these patients are probably resistant to a covalent BTK inhibitor, but not necessarily venetoclax resistant. So I think that opens up your options more broadly. And then, of course, CAR and non-covalent BTK inhibitors probably sit in the patients who are resistant to both classes more broadly. So that is a summary of what you might do if you start off with, for example, venetoclax obinutuzumab. Jen, I don't know if you have any comments on this or whether you have any sort of experience of knowing what to do with these patients in this particular setting.
That was a great summary, Toby. I don't have too much to add to that great algorithm. I think, like we talked about with the other algorithm, patients who have been on a BCL2 combination, who tolerated it well, who enjoyed a nice time off treatment, are probably going to be motivated to try it again. We really don't have any data for whether some patients might even be able to do this 3 times. It probably depends on, again, like how long their remission duration is in the second line setting. But certainly, just like if they start with a covalent BTK inhibitor, there's lots of options for second and third line treatment here.
Absolutely. So I guess one of the other questions is what we do in the relapsed refractory setting for patients that have been exposed to time-limited BTK and BCL2 based combinations. Now, we talked about this earlier. Ibrutinib plus venetoclax is approved and quite widely used in Europe and the UK. Acalabrutinib, venetoclax, plus or minus obinutuzumab, and then who knows in the future, perhaps zanubrutinib plus sonrotoclax or other combinations we may see developed. So this is, I think, an area of a real relative lack of data now. You can see here after fixed duration therapies, I think all options are open, really. These patients are, in theory, not resistant to either class of drugs. And of course, we're still learning about the therapeutic efficacy of all of these options listed here. Certainly, these patients have had a fixed duration therapy, so conceptually, another fixed duration therapy may be of interest to them. So re-exposure to BCL2-based therapy in relapsed disease may be very reasonable. Non-covalent BTK inhibitors could also potentially be an option here. But of course, these patients aren't necessarily resistant to covalent BTK inhibitors, so although one might be able to use these agents in this space, they may be agents that perhaps might be better saved for later. I think that could be debated. And then, of course, retreatment with covalent BTK inhibitors. Jen, you showed us data from the Captivate study, where actually now we have some data suggesting these responses are reasonably durable, with 2-year progression-free survival data for ibrutinib-treated patients looking pretty good. So I think this is an area with really very minimal data, but I think common sense would certainly suggest that all of these classes of agents will want to be used at some point. And of course, there'll be a number of factors that will help determine the sequencing preferences for individual patients. Jen, I don't know if you have anything to add here. It's obviously a sort of pretty new field, a new area of investigation. Have you much experience of retreatment in this particular situation?
Yeah, just a few anecdotal experiences where retreatment, again, with a covalent BTK inhibitor with a BCL2 inhibitor has gone very well. Obviously, still pretty early into treatment. But as you mentioned, with the venetoclax-based combinations with CD20 antibodies, in this setting too, with the BTK BCL2 inhibitor combinations, at the time of relapse, it has not been demonstrated that people have resistance mutations to either BTK inhibitors or BCL2 inhibitors. So likely all options remain open.
Great. Well, thank you very much, Jen. Now we've obviously walked through a lot of data and gone through a lot of ground here. I mean, I think my key conclusions really are you need to clearly think about the patient's preferences in terms of delivery, and also think a little bit more about the genetics of the CLL in the first line setting than perhaps we used to maybe historically. And clearly, sequencing of therapeutic options over many years will be important. The generation of data to help guide us, I think, will also be important. But these are great problems to now have. We have 3 classes of drugs, all of which are well tolerated, non-chemotherapy based options with really durable remissions. So a great time to be a CLL doctor for certain, with all these options and developments still to come.
Yeah, absolutely. And I'll just add, kind of harkening back to the CLL Society and PeerView survey we saw earlier. I think talking to patients in the frontline setting and as they go through therapies, noting that there are still lots of options remaining even after their first line treatment goes a long way to alleviating those fears that people have about what's going to happen when they relapse on their frontline treatment. Are there any options that are available still? So yeah, a great time to be taking care of CLL patients when we have so many of these options. Well, thank you so much, Toby, for joining me today. And thank you all for listening to this program. We hope that you found it helpful in taking care of your CLL patients.
Thank you, Jen, and thanks for all of you for tuning in.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, CLL Society. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/UMD860.